Hello, good evening, everybody. I'm Eric Renschart, and I would like to welcome you on this webinar from our society, the European Society of Medical Imaging Informatics. As you know, our society wants to stay abreast of all the developments in artificial intelligence, and therefore tonight we have a lecture about the application of artificial intelligence for the analysis of chest CT. And of course, I would like to give the word or to allow Yilmaz Pinas to introduce the speakers for tonight.
Thank you, Eric. It is my pleasure to introduce two amazing speakers for our first webinar of 2022. First, Professor G.Langs. He's the head of the Computational Image Analysis and Radiology Lab at the Medical University of Vienna. He's also a co-founder and chief scientist at ContextFlow, and he reviews for several conferences and journals. Among them are the IEEE, Transactions on Pattern Recognition and Machine Intelligence, and IEEE, Transactions on Medical Imaging. Secondly, I want to introduce Dr. H.Prosch. He's an associate professor of radiology and section of chief of thoracic imaging at the Department of Biomedical Imaging and Image-Guided Therapy at the Medical University of Vienna. He has published more than over 100 articles, reviews, and book chapters, and his research focuses on the diagnosis and staging of lung cancer and deep learning for the diagnosis of diffuse parenchymal lung diseases. If you have any questions during the presentations, please write them in the Q&A box. And we will discuss all the questions at the end of the lecture. And we also want to thank Brocco for sponsoring us for this webinar. Dr. Prosch, the virtual floor is yours.
Yeah, thank you and good evening, and thank you very much for having us. It's a great pleasure for us to talk about our research topics here in our center. Just before we get started, one needs to mention the conflict of interests. Georg is, as already mentioned, one of the founders and chief scientists of ContextFlow, and you will hear also about the product of this company later in our talk, and we did also research with them together. Okay, so in general, what are the roles of AI in interstitial lung diseases? And we will focus today on interstitial lung diseases, the applications of AI in interstitial lung diseases. And there are several potential roles for AI in that topic. One is the AI's support in reconstruction of images. We radiologists want to have great looking images with as low as possible, very low level of noise, and if possible also with a low radiation dose. And this can be achieved in one way or another using AI, but this will not be the topic of today's talk. We will focus today on other topics, and one would be automation, like the automatic lesion detection and the accelerated and improved reliability of reading. It is an important topic, in particular in interstitial lung diseases. Then an important topic, and this is also now important for our clinical routine, is the quantification of the involved lung tissue, because this has treatment implications and is also important for the follow-up of patients to judge on the treatment effect. And last but not least, diagnosis support is always helpful, in particular in these very difficult to diagnose disease groups like the interstitial lung diseases, as there are so complex patterns, and helpful enough if we can integrate the clinical findings with the imaging findings in one setup. And this is very promising, capture new phenotypes, identify why some patients progress while others do not. Probably that's because we just sum up patients with a similar looking appearance to one disease, although it could be many diseases behind that. So what is the role of imaging in interstitial lung disease? And there are many. It starts already with the early detection, and this is where AI may play a role. The diagnosis of the type of fibrosis, if we're talking about fibrosing lung diseases, which will be a subtopic of today's talk, then the prediction of disease progression, and then last but not least, the monitoring of disease course, as mentioned already. So what makes these interstitial lung diseases so complicated? And it's, for one, there are so many. We know from the literature and also from our daily life that there are many, many of these interstitial lung diseases. These are diseases which diffusely affect the lung parenchyma. We know that there are between 200 and 500 different diseases. The problem here is that most of these diseases are very rare, and the CT manifestations overlap to a quite substantial degree. So this is why most of our radiologists do not really like to read the CT scans with interstitial lung diseases, as this can be quite complex, and you have to go back to your textbook to look for specific information to tackle the diagnosis. When we limit our discussion now to interstitial lung diseases, which are characterized by a scarring of lung tissue, that's what we call a fibrosing lung disease, there are in particular 4 groups. So one is the most common one, which we call the usual interstitial pneumonia, is not a disease in and of itself, but the CT manifestation or the pathological manifestation of several different diseases, like the idiopathic pulmonary fibrosis or connective tissue disease related diseases, and many more. Then there are the non-specific interstitial pneumonias, as well the chronic hypersensitivity pneumonia and fibrosing granulomatous diseases such as sarcoidosis or mineral dust leading to fibrosis, the so-called pneumoconiosis. So this sounds easy enough. The problem is that in individual cases, this can be tricky. And to help us with the diagnosis, there are criteria, in particular for the UIP, which is the most important here when it comes to prognosis. There are criteria. And what you need to see in the patients in order to diagnose a UIP, usual interstitial pneumonia, you need to see reticular abnormalities. You see these crisscrossing lines here next to these multi-layered cystic spaces we radiologists call a honeycombing. And this has to be seen in a particular distribution. And as you can see here in the sagittal view, you see here that there is a clear basal and dorsal predominance of these findings. And taken together, listing all these criteria just mentioned, if a patient fulfills all of these 4 criteria, you can diagnose that disease without a biopsy. The most important factor here is the honeycombing. You see here these cystic spaces, and this is the hallmark of this disease. So if you see that, you can diagnose the UIP without a biopsy. Sounds easy enough, but how easy is it to diagnose this honeycombing? And it was quite a surprise to see that if you look at specialists or also non-specialists in interstitial lung diseases as investigated by this Japanese study, the Interobserver Agreement is between 0.4 and 0.6, which is a moderate Interobserver Agreement, which is not that good for the most important diagnostic criterion. And reasons for that are manifold. And one is that this honeycombing may look like emphysema. This is a patient with emphysema, as illustrated here, as we also have the previous exam in this patient. And on a follow-up scan, this looked like honeycombing, but instead, this is still not honeycombing. This is just emphysema. Another example where it can get tricky is this case here, patient with non-specific interstitial pneumonia. However, you see that on this Excel slide, it looks like honeycombing. But if you then reconstruct that picture using multiplanar reformations, minimum intensity projection, you see that this is not honeycombing. These are just traction bronchiectasis. And this leads to the problem that even expert radiologists do not agree that well when it comes to the diagnosis of UIP, possible UIP, inconsistent with UIP. I do not get into details here, but these are the diagnostic categories we have for the diagnosis of UIP. But what you can see here, this is difficult even for experts, let alone for people, normal radiologists, general radiologists who do not see cases like that on a daily basis. So this is where AI comes in. And we need AI, or we hope to get help from AI for the diagnosis of interstitial lung diseases in general, and for these fibrosing lung diseases in particular, because as I just showed you, we humans are not that good at diagnosing, at identifying complex CT patterns, and we need to identify these relevant patterns because these are of diagnostic importance. And this also leads to problem that we are not able to predict individual prognosis, and we are not able to predict individual response to treatment. So there are a lot of questions where we hope to get help from AI, and what we see from the literature and also from our research, this is something we can achieve in the near future. And with that, I hand over the microphone to G.Langs, the computer scientist who works with us. He's the head of this research group here.
Thanks, Helmut. So in the next couple of minutes, I'd like to go a bit more into detail about the technical parts of how we can use search. And maybe you wondered why search might be relevant in helping radiologists when they really want to do diagnosis. And one of the reasons, or there are a couple of reasons, some of them Helmut already mentioned, that it's sometimes tricky to identify a certain disease pattern, so then link that to the diagnosis. And there it's helpful to get comparable cases, get similar cases, to learn from them, to see them, to also be able to compare them to your current case. The second direction that we'll discuss a bit more technically, and also then in some results to illustrate what the impact of that is this thought that Helmut mentioned, that there is a certain number of diagnoses, of categories of patient groups that we know, but they are a result of how we approach these imaging data, these patients, when we look at them, at the data, at the imaging data as humans. But it turns out that when you use machine learning to interpret imaging data, there are other features that become tangible, that become useful and usable in order to find patient groups. And we see on a couple of examples that we are able to find patient groups that are relevant for the outcome, for the future of the patient, that are on a more fine-grained level that we do today with the diagnostic categories that we are working with. The primary motivation for search, or this idea of finding similarity relationships between patients, is that we are talking about educational material, but there is a lot of data that we are acquiring in the clinical day-to-day practice. So we have, that's just a typical radiology department, many hundred thousands of imaging exams per year. All of them come with the imaging data that gets more and more fine-grained, more and more high resolution, and captures more and more features of the physiology, of the disease effects, of the correlates to the disease. But these patients also come with the reports of the radiologists and with the clinical history, both before the scan was taken, but also, and that's the interesting part, after the scan was taken. So we can get out of the hospital systems what will happen to a patient, what treatment was performed for a certain patient, what was the outcome, what was the response to a certain treatment, or what was just the course of the disease for this patient whom we scanned at a particular point. And the idea of search, or content-based image retrieval, as it's known in the technical community, is that we have an example, a certain case that we are looking at, that we want to learn more about it. We perform feature extraction, and very often this feature extraction is already influenced by machine learning methods in order to ensure that the features that we do extract are actually relevant for the disease that we want to diagnose, or the disease family where we want to perform differential diagnosis. We use this feature extraction on the particular case to go into a database of many cases for which we know the features, and for which we also know clinical information or diagnosis that we want to use to assess the one case that is in front of us right now. We use these features to find similar cases. So these features, you can imagine them as a big landscape of positions where similarity means that these cases that are very similar kind of are in little clusters in these landscapes. And what we are hoping for, or what all the machine learning work attempts to do, is that these clusters, these groups of cases, are meaningful in terms of diagnosis or prognosis. And so when we have a feature vector of our case, and when we have this data bank of other cases with corresponding features vectors, what we can do is we can just look at the nearest neighbors of the current case and use their clinical information, their diagnostic information, in order to help us understand our particular case better. And that might be just understanding the diagnostic category in the diagnostic categories that we know of, but it might also go a bit more fine-grained, on a more fine-grained level, in showing us the exact neighbors, the exact similar cases to the case that is in front of us, because there might be more information in this large population of patients who had a similar disease and who underwent maybe a similar pathway through treatment, recovery, and outcome. So let's dive a bit more into the technical parts of how to think about it, what we can do with that. So I'll go first for the kind of more method part of the description of what you can do in order to find these clusters, in order to span these landscapes that capture features that are relevant. And then I'll show with a couple of examples what that actually means in terms of our capability to predict something about the future of a patient. So in a similar fashion, you can just imagine that we represent a lung CT in a feature space. So feature space just means a column of values. And here in these representations, you see every column is a patient, every line is a feature. And for now, we just extract features like the roughness, the texture, the location of the texture out of this lung imaging data, because we can, and because we think that providing algorithms a wide variety of features that are candidates for actually being valuable is a good first step. We don't want to by hand reduce the feature space. Instead, what we want to do is we want to let algorithms decide how you reduce the feature space. And that can happen by traditional methods or not deep learning methods. Machine learning methods, like in this case, latent Dirichlet association, where you see the first kind of this big band of features. That's a lot of input features. Many of them might be totally irrelevant. Many of them might be just noise, but some of them carry a certain co-occurrence pattern. They happen a lot of times at the same time, at the same location in the lung. We can learn from a large patient population what is a vocabulary of patterns that happen over and over again and are therefore candidates for being valuable to describe what is happening in the lung. So what you see on this little bit more narrow band is this kind of reduced dimensionality of a feature representation. And there you see that we have a couple of vocables, a couple of, let's call them words, that represent what combination of features is happening in this case, is present in this case. And they are already sorted following a clustering algorithm. So you see here 3 groups of patients that have a certain presence or a certain activation pattern of a certain kind of lung tissue occurrence, lung tissue appearance in the imaging data. So that's good and nice, but we don't yet know if it's useful. We just see that we can find groups in the patient population that look similar, and we can map this similarity to the presence or absence of certain imaging patterns that an algorithm has extracted from a large patient population. What does that mean? Is that meaningful or not? So one experiment, and that's work by Johannes Hofmanninger, together with many colleagues, he did that and then checked whether the clusters and the presence of these visual words actually coincide with terms, with findings that were reported in the radiology reports of these patients. So what you see on the lower part of this plot is, for these 3 clusters, which words were present or absent in radiology reports. And you already see that some of these words, some of these clusters coincide very nicely with certain terms like emphysema, fusion, or cysts that are reported in the reports. And so we can actually find clusters in the patient population with significant, let's call it, expression of certain patterns that are meaningful and relevant to the radiologists, and kind of meaningful in order to communicate them to downstream decisions and downstream treatment and patient management decision making. So that's encouraging because it shows us that we can capture something out of imaging data that's meaningful. But we would like to go one step further and say, and ask if there is also information in the imaging data that is not yet used by radiologists, that is not yet present in the vocabulary, in the way of how we report imaging cases. And one experiment that has been done, again, by Johannes Hofmanninger, and that is work that is submitted, but not yet published. But I'd like to show a couple of initial results because I think they're really, like, they give us some idea and some intuition about where this can lead. So in this experiment, he used an autoencoder, that's a deep learning neural network structure architecture that kind of has the idea to represent data and find a compressed representation of data by pushing it through a bottleneck, with the cost function being that the inside of the incoming data is very similar to the outcoming data. But since the model has to press it through the bottleneck, it is kind of encouraged of finding efficient representations of the variability that we see in the data. Now, this efficient representation you can again interpret as some kind of activation of these bottleneck neurons, where the activation of a certain neuron means that a certain pattern is present in this particular case. And on the right-hand side on this slide, you see a couple of visualizations of what these neurons correspond to in terms of typical cases that have very high activations on this neuron. So it's kind of a signature that captures, that summarizes what's happening in this scan. Now you can take that, it's a compressed representation, and we, again, like all of the features, the smaller band is this bottleneck representation of the feature space. It gets a bit more complex, it captures a bit more. And now we don't test if it corresponds to radiology reports, but we do test if it corresponds with clinical findings, clinically reported conditions, observations in these patients. It turns out, again, you can think of it as an expression table, that some of these clinical findings, some of the diagnosis treatments are over or under expressed in some of these clusters in the large scale population. And then you can think of this population as actually a collection of phenotypes, a collection of clusters of patients that look very similar. And here in this plot, it's visualized if every row is one of these phenotypes, one of these clusters, if there is a certain over or under expression of a clinical condition, of an outcome, of a diagnosis, of some treatment that was performed with this patient. And so we see that that gets us a very kind of diverse and very kind of encompassing representation, and also a very fine-grained representation of the patient population. But the question is, what information is in there? Think about these columns and think about them as points in the feature space. And for simplicity here, Johannes created a two-dimensional embedding so that it's a bit simplified, but it gives us the overall picture of what we can see in terms of similarity structure. And when you think about what does that have to do with search, it means when we perform search in a space, we are just looking for the nearest neighbors. We take an image, we want to see what images are similar. The images that are close by in this space are similar. So let's have a bit more kind of detailed look on this space. So let's just look at the distribution of cases. So it's the entire population of patients, CT imaging data of patients collected over a couple of years. We see there is some distribution, not very specific, but it shows us some structure. But now let's ask, are there certain regions that are populated by patients with certain outcome, with certain diagnosis? So for example, here there is a region that is populated by very high-risk patients with very short survival. There is another region populated by cystic fibrosis patients. Here is kind of a more distributed area collection of populated by patients, in this case, who then later on suffered from acute respiratory failure. And overall, it captures structure in the imaging data that is associated with the medical condition of these patients. What it also does, and I think that is a community here who understands that very well, is that it does not only capture, of course, characteristics of the disease and the physiology and the anatomy, but it does also capture characteristics of the image acquisition technology, right? So it does make a difference if I'm scanning with 2 mm or 1 mm or 3 mm resolution. So there are also kind of biases in this landscape that are coming from the actual image acquisition, but it turns out when you test for that, that there are independent signatures of disease and outcome in this representation that can be decoupled from the signatures that are coming from the technology. And that leads to the fact that the signature position here, and again, these are preliminary results, does actually have a quite good predictive value. So this is an experiment where Johannes and his colleagues tested whether when we take this signature, in addition to other clinical information that we have, like the ICD codes, the age, the sex of the patient, does that give us additional predictive value versus the risk of these patients? And it turns out if we, for both long-term and short-term survival, that was the benchmark in this case, we do get an improvement of the prediction capacity of the model. So these signatures do carry information that is not captured in other data sources that were compared with it, like the clinical information and other demographics information of the patient. So they do carry additional information and are worth mining further. So that's one side, but the other side is it's nice to have a predictive model, but it's better to understand what's happening in this predictive model. So we don't only want to get black box prediction models that tell us something about a risk score or risk factor. We also want to understand where are these models taking the features from, what do these features mean potentially in order to help us understand the disease or the mechanisms that are underlying the disease and potentially also the response to a certain treatment. So when we go back to these phenotypes, what we see is if we compare them, that we can see that there are groups, in this case, these are patients who all suffer from cystic fibrosis, but they are falling into two different phenotypes that also come with different clinical manifestations and also with different demographics. So it seems that we are able to identify different groups in this diagnostic category. Another example is that here we have part of this embedding, and we see two clusters. So they are, I hope, somehow visible even in this two-dimensional embedding. They seem a bit close, but like in the actual 20-dimensional embedding, they are very clearly separated and very stable clusters, like this light green and the dark green cluster. And what we see is both of them have similar clinical features, but they have very different risk. So the survival curves, unfortunately for these patients, are very different. So we can plot them and look at the difference and also the variability within these clusters. They seem very clearly separated. Now, the interesting question is, if we see this separation, what is the reason? Is there anything in the imaging data that we can associate this differential risk between the groups? And one thing that we can do is, again, go back to these activated neurons and ask, are there certain patterns in the imaging data that are overexpressed in one group and underexpressed in the other, or the other way around? And what you see here is this low risk bright green group has an overexpression of the area that is here marked with bright green, and the high risk group that has an overexpression of the areas that are marked here with dark green. And you see there is quite a difference in the presence of these areas, of this type of patterns, where one seems to be fairly normal lung pattern and the other one bit more hyper intense lung pattern. So we can basically trace down these signatures to actual areas in the imaging data. And that means that we then have kind of a connection point, an interface where researchers who are understanding the biology or working on understanding the biology and possibly also treatment effects can have a closer look at these particular points in the lung, look at what they have in common if they are associated with high or low risk. I'd like to show you two more examples that go a bit more into specifics on specific conditions and using this idea. One is using these profiles, this position in the landscape, and again, kind of the similarity, the neighbors in this landscape, in order to say something about acute respiratory distress syndrome in a emergency patient population. So here we see basically just the features of a cohort of emergency patients who had a CT scan within 1 hour after the accident. Every column, one patient, every line, one feature, already grouped into clusters. And when we are looking at these clusters, you see that there are 4 groups in the population that look fairly similar. There is some differentiation between the groups, but overall there are 4 very strong and clear clusters in this population, just looking at the imaging data. First question, does that correspond to any of the established risk scores? It does to some extent. So for example, this ARDS Thorax is an established score that is used in these circumstances, and there seems to be some correlation with the clusters here. But the interesting thing is, if you then look actually at what happened to these patients, did they actually experience ARDS, yes or no? Then we see there is a very strong clustering of cases in this one visual clusters. And this means we can find clusters that are meaningful in telling us something about the future of the patient. And it also means that when we compare what we can do with established clinical scores or what we can do with these visual signatures that just use the fact if cases are similar, if they are in a certain area in the feature space that seems to be high risk or low risk, then we can actually outperform these risk scores and make a better and more accurate prediction about, in this case, ARDS. So this is work by Sebastian Röhrich, Johannes Hofmanninger, and many others, a collaboration between radiology and emergency medicine. We can, like in the last example, again, go back and look what are the patterns in the lung that are associated with these groups. And now that we have these patterns and we understand them a bit better, we can also look at their dynamics. And that's more recent work in the area of fibrosis. When we look at the dynamics of these patterns, how they kind of develop in larger cohorts of a certain disease or a certain outcome, we can not only say there is lots or little of a certain pattern in this or that patient, but we can also say this pattern gets more or less. And what's even more important, we can say at the position where this pattern emerges, there was a different pattern at the time point before. So we can talk about pathways of pattern transitions that are happening during specific diseases, in this case, lung fibrosis. And one of the important insights, and again, these are preliminary results by Jenny Pan, which is currently under review, we see that there is also, again, predictive power in these dynamics of the profiles. So this was a bit about kind of the method and results that show that it makes sense to look at feature spaces that are spanned by visual features, in this case of lung CTs. But now, in the next couple of minutes, before I hand back over to Helmut to show us a bit about recent studies that were done in this context, I'd like to show a bit about how they can be put into practice. Like, how can we use that understanding, that insight, that similarity is meaningful, to put it back into clinical practice. And so this is now results of the collaboration with ContextFlow, and that is a spin-off that went out of some of the projects that were happening in our lab. So what does that help a radiologist when a radiologist is performing the actual reading? It helps to identify patterns that are maybe difficult to identify or confirm them. It helps to find reference images of cases that are similar, and it also helps with the differential diagnosis. And there are two main challenges when we are taking this methodology and putting that into practice. One is we need a good similarity function that actually captures disease similarity, pattern similarity that is associated to something diagnostically meaningful and not just technology. That's one. And the second one is we need speed. So we need to perform this comparison at the point of care. And that means the time budget is maybe half a second or maybe a second, but rather we'd like to finish these comparisons within half a second. And here a comparison doesn't only mean between case to case, which might be covered with a couple of thousand comparisons, but actually with a couple of billion comparisons between a certain place in the image to places in the image in this large database of images. Here you see what that means. It means that for a certain point in an image, we can kind of span out the similarity across other cases in the reference database. That means we can collect these cases and then use them for differential diagnosis. It also means that under the hood, some of the similarity function, part of the similarity function is actually based on what we know in terms of disease patterns. So we are not going into this, we don't have to go into this blindly. We can do partly unsupervised learning, but we do actually, or we can actually exploit our understanding of the patterns that Helmut just explained, like that there is honeycombing, that there is ground glass opacity or reticular pattern, perform kind of a quantitative profiling of a certain case that helps us in the diagnosis, in the assessment, and also in kind of saying something about this particular case, but also this particular case over time. And that means we can basically transition from things that were done with nodules, looking at them, tracking them over time, to doing that also with disease patterns, to understanding and tracking what happens to disease over time, how do these patterns change in a patient, and where are we in the progression of the disease for a patient compared with other patients. 3 slides just to show you some examples how that can be put in a user interface. This is an example of the user interface of the quantification of the patterns, how much of each pattern is present in a case, how much anomaly is present in a case, and where is it distributed spatially. Is it happening in small kind of little focal lesions, or is it happening all across the area, all across the lung volume? It's sometimes interesting to see that also in correlation with the position and the presence of lung nodules. And we can then go use that information, go deeper and look actually, are there cases that are carrying similar areas? So here is an example where a certain region of interest is marked. Cases with similar findings are found and collected, and we see both the spatial distribution of the finding that we marked in an image that tells us something alone, but it also tells us something in the connection with understanding what's the spatial distribution of this finding in the comparison cases. And with that, I'll hand over back to Helmut, who will talk a bit about studies in terms of what is the actual clinical impact of context-based image retrieval. Thanks.
Thank you very much. Yeah, I move on and just would like to share with you two studies. One was very recently published in Radiology. The other one was performed here and is now about to be submitted. And Georg showed you this slide already. So the principle behind this content-based image retrieval system is that you are marking a certain area in the lung parenchyma. The features are extracted, and these features are then queried in a feature vector database. And what you get are similar cases. And the principle behind that is not very new, and this is already implemented in several more research platforms. But there is now a publication out there, very recent, published this month in Radiology. And what they did is, as a study group from Korea, they used a study set of 288 patients, and they limited this study to 4 primary diseases. And these were the ones I mentioned before in my introduction: the usual interstitial pneumonia, the most common type of lung fibrosis, then the non-specific interstitial pneumonia, the chronic hypersensitivity pneumonia, and the cryptogenic organizing pneumonia. So if you're not familiar with these diseases, just a reminder, these are diseases which are very important when it comes to the prognosis of patients. They're not that uncommon, and there's a significant overlap in their CT manifestations. And they asked 8 readers to read these CT studies. They did not read all of them. They divided these study population into 2 subsets, each of which comprised of 80 cases. And each reader had to read the cases without the help of the content-based image retrieval system. And then the second time, another set with using this content-based image retrieval system. And in this system, they used the system provided the reader with 3 cases, which, according to this software, looked pretty much like the case which they were investigating. So, and then by looking at these comparable cases, they could come up with a diagnosis, the most likely diagnosis, or also an alternative diagnosis. And remember, these are very difficult diagnoses. And if you look now at the performance of these radiologists, this is the performance of all 8 radiologists. This is the true diagnosis versus the Regius predicted diagnosis. And if you look here, the concordance here was not that high, about 20% when it comes to UIP, and it got even worse if you go down to the chronic hypersensitivity pneumonia. So this is probably also due to the fact that these are most likely quite challenging cases. However, this is something we see also in our daily life. The diagnosis here is quite complicated. And if you then also get the help from this software, the content-based image retrieval system, the overall diagnostic accuracy increased significantly and also relevantly for all of these diagnoses. Apart from the, not all of these diagnoses, for UIP and NSIP, for chronic cryptogenic organizing pneumonia and chronic hypersensitivity pneumonia, the effect was not that high. And this is presumably because, in particular for chronic hypersensitivity pneumonia, we know this also from our daily life, that this disease is so heterogeneous in its manifestation that the effect you might get just by getting to see 2 cases is probably not enough. But this effect was seen across all readers. All profited to a variable degree. The board-certified radiologists, not as much as the non-radiology physicians, but you see this increase in the diagnostic accuracy all over the board. What is not really surprising, if you also take the 2 top differential diagnoses, then you see a substantial increase in the diagnostic accuracy. But if you just provide 4 answers, 1 and then a second as an alternative, it's not really surprising that you see a substantial increase in the diagnostic accuracy, but overall, this is very encouraging and helps. But remember, the readers were only shown, were only allowed to see 3 of similar looking cases. But as you recall, the chronic hypersensitivity pneumonia is very heterogeneous, and we see this also sometimes in the other diseases like in UIP. So this probably is not enough. And there's another option. What you could do, you could go with along the same steps. The feature vector database provides you with similar cases. But in addition to that, the same software can also provide related information from the internet. And this is something what we also do in our daily life. So whenever we see something and we don't know much about that disease, we go to the internet. Many of us, if not most of us, go to Radiopedia and look for similar cases, look for relevant information. And if a software is able to provide us with information specific to a case, this would be of great help. And this is what we investigated in the other software. This is developed by ContextFlow. What we did is we took 108 cases with a diversity of ILD cases, so not just for lung fibrosis. And each of these cases was read 4 times. But remember, each case was only read once by one reader. No case was read twice by the same reader. And we had 8 readers. We asked 8 readers to go through these cases. And we used then 27 cases. And the readers, when they read the cases for the first time, they could use and were encouraged to use databases they use in their normal life. They could use textbooks, they could use the internet search, whatever they wanted, whatever they did in their daily life, they were encouraged to do that. For the second session, they got to read other 27 cases, but then they were also provided with this image retrieval system, which provided them not only with comparable cases, but also with specific information from Radiopedia. So set up like that, the baseline reading session, they had to come up with a diagnosis, a differential diagnosis, and this process was timed, and the same holds true for the trial session, where they were, in addition to the normal textbooks and normal internet search, were also getting help from this context-based image retrieval system. And no big surprise here, because this is a novel tool and they were encouraged to use that. They used this search tool quite a lot. They searched more often when they were able to get this software than they were doing in their normal life. Also in their normal life, they used the internet, but not as commonly as when they were provided with specific tools. So more common, if you search more often, one might assume that this may lead to a longer searching time, but the contrary was true. As this information was provided specifically, the grand total reduction in time was 20%. And if you are then correcting for the experience of the readers and for the frequency of the searches, you can see that the effect of this time sparing is even higher. It's about 30%. And more encouraging and more interesting to see is that this effect was seen not just in juniors, but also in senior radiologists. So this is this kind of a specific search tool can be helpful for all radiologists. And with that, I move on to Georg.
Thanks. So in the last 1 minute, I'd like to give 2 thoughts on the way about currently ongoing work. The first one is that in a collaboration between Medical University, University of Cambridge, and many other partners in the ICE-COVNET collaboration, we are working on COVID-19 data and are trying to understand how we can use the data in order to perform or build robust prediction models. And here these quantitative profiles that can be extracted from the CT imaging data turn out to be predictive regarding the outcome and the risk of individual patients. I think we know some of that, but I think we also know or understand now that can be a good and solid building block of prediction models that can control and inform the treatment of these patients. And the last thought is ongoing work, and there is a first publication by Matthias McConing in Nature Communications about the challenges that we coming up, and I think the entire field is coming up against, and that is while we are training and developing machine learning models, the world moves on. There are new types of diagnosis, there are new types of treatments, but there is more, or as a first challenge, also upcoming new imaging technology, newer scanners, more higher resolution, different imaging characteristics. And I think we have to find a way as a community to also deal with that. And that is why we are starting to look more into the area of continual learning that has as a goal to expand or continually expand the capability of machine learning models to learn to deal with new data while kind of exploiting the model knowledge that was trained on older technology data, while at the same time also not forgetting to work well on older data. And I think we will see more of that. And with that, I'd like to thank you for attention, for sticking around, for the invitation, and I'm looking forward to questions. Thank you.
Thank you so much for this great presentation and the overview of all the studies you've been doing within your group, and also the perspective for the future, of course.
Thanks.
So there's a first question from Christian Lutjen, who also says, thank you for this excellent talk. You seem to have worked primarily with study level labeling through radiology reports and ICD-10 codes. Have you also used annotations made by radiologists to identify regions corresponding to the known patterns like honeycombing?
Yes, maybe you want to.
Yeah, these are very important topics, and this annotation is important also for search tools, but also for other applications. The thing is, the problem we have with these annotations is that the computer can only get as good as the radiologist. So we know that, and I showed you the data before, that we radiologists don't agree that often on what is honeycombing and what is not. So there are certain cases which are very straightforward, where they're easy, but there are more difficult cases. And in these cases, the computer will then also struggle. And this is why one could also follow the road of unsupervised learning. Georg can follow up on that as well. Or the other thing is that the computer shows you similar cases and then provides you with tips and tricks how to differentiate that, so that the computer does not give you the diagnosis, but shows you a narrow differential and provides you with specific information, so that it helps you to diagnose, but does not come up with a diagnosis, because that would probably still too much to ask.
Yeah, maybe just to add a couple of minor points. One is that, like Helmut said, I think the benefit of unsupervised learning is that it basically identifies patterns that can be identified in a stable, in a robust fashion, because then they turn up as clusters across the entire population. So that is, I think, the strength of unsupervised learning. The strength of the supervised learning part of actually going for the honeycombing and GGO and other patterns that radiologists are using right now is that we know that they're associated with disease. So like Helmut mentioned, I think we still have these limitations that they are difficult to assess and difficult to mark and annotate during the training. But even though that's the case, I think one advantage you get even for these patterns with machine learning is you get precision. So you get stability in the identification of this type of patterns in longitudinal scans, but also in kind of comparisons across individuals. So I think both of them are valuable parts, but I think it's important to have in mind that this unsupervised learning can expand this vocabulary to other patterns that are also possibly associated with disease and give us just more expression power in comparing cases and also linking what we see in the imaging data to the diagnosis.
Thank you.
So it's not one or the other, but I think it's just an expansion of the vocabulary.
Because I was thinking that if you would have a combination, I mean, the thoracic radiologists are trained for this. So if you have them as a start for your golden standard, and then put it out for your unsupervised learning, in which you can build the prediction modeling within the group of data that you have, is that a step That
I think that makes a lot of sense. I think what also surprised us is that what we saw is that you can go also the other way and start with unsupervised learning and then let Helmut, for example, or other experts look at these patterns, and then they actually get a feeling what it is, right? So then they can put some biological tags.
Meaning to what the model finds. Yeah, that's also makes sense. Because I had a question that was very interesting, which you showed with the different data collections that you have and the signature, how additive that can be. I mean, I think if you would think about applying it within the clinics, if you can, I mean, imaging is almost always included within diagnosing or treating a patient. So if you can integrate that in this background model, I know that, for example, within Netherlands for prostate cancer, that's a step forwards that they're trying to implement, so that you can get a longitudinal assessment of the patient, in which you can grab different parts of information, also the longitudinal scans that are being made, and to capture those differences. How do you think, because I mean, aside from that, I think the thorax is one of the fields in that there are a lot of similar signs that can mean different things. So I can imagine that this field's very challenging to capture those different signatures.
Yeah, I think that's why I think that unsupervised learning is really important there, because we have a very limited vocabulary in thoracic imaging. So if you just look at ground glass, so ground glass can be just very homogeneous or can be very fine reticular, and the radiologists tend to, we have difficulties to discriminate that, first of all. And then I'm sure that by using the machine, you're able to get a more fine granular description of something we all would describe as ground glass. Just to give an example here. So I think unsupervised learning is the way to go, but with supervised learning, you can get more help. And then if you get in addition to that clinical information, this is the next dimension, then you can get much better learning set.
Thank you very much. I really like the presentation you gave. That's very, very exciting material that you showed, also the research, of course. But I do have two questions. One is the more practical one. That's the first one. So if you, what do you think are the most important incentives now with this type of AI tools being available? What are the most important incentives for radiologists to start using it? Is it the reduced time, the timing that is reduced for providing reports and analyzing the images? Is it the accuracy that is increased? Or maybe is it the best way to reduce the workload? Or maybe is it even to resist the pressure coming from other clinicians asking the radiologist to use this type of analysis to provide a diagnosis? So what do you think?
You forgot the last checkbox, which is all of the above. I think if it can speed up the diagnostic process, that's something we all love, because then we can go to drink our coffee. But in particular, the hospital wants us to diagnose more at the same, to get in 1 hour more examinations done. So I think time is of the essence, and that's something which is important here. But for our daily life as well, if we get help to narrow the differential diagnosis, if we can get more confident with our diagnosis, that's also something we really need and appreciate. So I think it's not just one thing which is the only thing which should convince us to follow that track. I think we can get more than just one thing.
Yes, and then my second question is a more theoretical one or philosophical one. So now we do know that AI is able to detect new combinations and to combine features, not only imaging features, but also clinical features and even phenotypes. So the amount of information that we have to, let's say, integrate is becoming quite complex. Even certainly if we want to make predictions in a diagnosis, it's not only making a diagnosis, but also in making a prediction or deciding about the therapy. In what way, how, well, suppose this is all being developed further and made available in a commercial version, what is the risk, do you think, of radiologists becoming over-reliant on this type of solutions? There might be, yes, aren't you afraid that there will be an automation bias, or that we will become afraid of using or let's say making a different diagnosis than or prediction than what the AI solution provides us?
Yeah, as always, you have very difficult questions.
I'm not trying to be difficult, so I'm sorry.
Yeah, the answer is difficult to give, because I think we all tend to, if something is difficult, you try to, probably you rely on that help more than you should. And this, I think, is one of the obstacles we need to tackle. We need to train also our younger radiologists, people who are not that familiar with these machines, with the techniques, to be aware of problems, and there are many. Yeah, and also the software should come up not with a diagnosis, but like we know from other fields, the Z-score or something like that. So the probabilities, and again, that's a topic which many radiologists do not like too much. If you just get the probability and not the real diagnosis, but that's our life. So when we come up with a diagnosis, that's also just a probability of a diagnosis. And in particular with these interstitial lung diseases, as I mentioned, there are so many, and you can't expect that one single software is able to diagnose all of them. So it's just able to narrow the differential diagnosis, and then it's getting even more challenging for us, and we can do even more than just come up with one diagnosis. We are then more integrated in the diagnostic workflow than before.
Yes, I see. I completely understand your answer. Yes.
I just wanted to comment on the first part of your question, that there is kind of like that these algorithms and models generate even more information than there was before, and it actually kind of potentially adds to the workload or to the kind of challenge of interpreting the data. I think that is something that we absolutely observe, that a lot of what we showed here and what we do, there were many iterations, and there were really interesting and challenging iterations on finding out what exact information is helpful at what exact point in time, right? So there is information that's great, but at that point in time, it's not helpful anymore, or it's not yet helpful because it's like you would wait for this other exam anyway. So I think one of the challenges that I'm coming from the technical background that we have to solve, and that's just on the path to actually putting that in practice, is understanding what part of that information is valuable at what time point. It is not all of the information all of the time, but like some bits of this information really help in making decisions, or in making decisions that actually change the treatment versus other points. So I think that is part of the optimization that also has to become, or is becoming more and more part of the development, this design of what information to deliver when.
Yes, I agree with you that the human in the loop is still important, and it will remain like this for quite a while, I think. But nevertheless, as radiologists, we will have to learn how to use this, because I'm afraid that others will start using us if we don't. So that's certainly something that we have to keep in mind, and we also have to be aware of the potential pitfalls of using this kind of software as well, of course.
Yep.
I don't know, maybe Pinar, do you have another question?
I actually particularly like the last thing that you showed with the tool, in comparing that with juniors and seniors, and what Eric also mentioned in, well, one thing, there was a time reduction that it helped to get to a differential diagnosis. I was thinking of, because there was a small set, of course, in, I guess, a study setting, is this a plan to implement this, for example, also to get the junior or the younger radiologist to be more integrated, but also to gain, I guess, more data and to develop develop the tool even further. Like I was just thinking of the other side. I mean, of course, if you rely too much, or the bias that bias is everywhere, and the other part is already integrating it as a study, but also as a learning point, I guess.
Yes and yes. We are integrating them also in the development of that, so in the research projects. And what I found quite interesting is that they when they were reading the cases, they were they were accessing the Radiopedia more often than they would normally do. And by doing so, you learn more about that than you would normally do, because otherwise, if you just read and start from nowhere to get to the specific information, you're losing quite some time. And by getting the specific information, the likelihood that you're searching is much higher, because you're not losing time, and at the same time you're learning. So this was very well appreciated, not just by the residents, but also by the attendings.
Yeah,
because
I can imagine.
Yeah, that's quite a challenging field.
Okay, thank you.
I have a last question, maybe. Yes. So the technique is also changing. It's not only the computer-based technology, but also the imaging modalities. And as you know, we do have new machines coming up for CT, like the photon scan. So how do you think this will influence the accuracy of the algorithms? And what impact will this have on the availability and the accuracy of algorithms? Because of course, if you want to deploy an algorithm in different hospitals, in many hospitals there are many different machines, and I can also imagine that if you use the newest machines and the newest technology, that the software and the algorithm will also be able to learn more from the images.
Yes. So so I definitely think that, like, as the imaging modalities get more advanced, and like if you see more in the imaging data, then also the algorithm can exploit more out of the imaging data. And so I think like the algorithms will continue to develop with these new imaging modalities. But I think one interesting observation that we made in Matthias Perkonik's paper was, so the experiment was a couple of scanners follow each other. And now what happens when you're switching to a new scanner and then switch again to a newer scanner? And one thing is that it's a good idea to keep some of the model trained on the old scanner, make sure that it continues to work on the old scanner, and expand it to the new scanner. And there are two observations. One was that the model that is kind of trained or kind of adapted to the new scanner benefits from the training that happened on the old scanner. So then it's get better than just the model that just trained on the new scanner. But it's also working the other way around. So the model that is trained also on the new scanner then also gets better on the older scanner. So I think there is information transfer happening. So there is this backward and forward transfer, and you see that quantitatively happening. And so I think like the benefit is both ways, but it also means that we have to make sure that these models don't kind of stop to work on machines with lesser resolution, because like it's important to have broad availability. But I think our surprising insight was that you get this transfer towards other machines by training on specific machines.
Excellent, thank you very much.
Thanks.
Yes, I think we might conclude now. We have reached the hour. So I would like to thank you again for this really excellent presentation.
Thank you.
It was very insightful, and of course also amazing the way progress is being made. So thank you again, and I would like to inform all our attendees that this material, this video, will be made available on the platform of our society, USOMI, and we also have a YouTube channel where these images or these videos can be accessed. So thank you very much again, and I hope to meet you all live soon again.
Thanks for the invitation.
Bye.
Thank you very much. Bye.
Bye-bye.